I'm sure all of you would have been heard about this bone marrow examination in our private practice. So this is one of the most important diagnostic procedure to assess various hematological disorder. Apart from hematological disorder, still there are various non-hematological disorder where bone marrow study is important. To talk about this topic, I call upon Dr. Priya Murthy. Dr. Priya has completed her MD from Dr. B.R. Ambedkar Medical College. She is currently heading lab operations and hematopathology for the Bangalore Reference Laboratory, Dr. Lalpath lab. Prior to this, she was associated with Onquest Laboratory Limited for nearly 9 years. She has worked with Metropolis Healthcare and Piramal Diagnostic Services. She has nearly 19 years of experience in the diagnostic and service industry, with experience in various fields of pathology, including hematology, clinical pathology, histopathology, and quality assurance. Her field of special interest are hematology and bone marrow morphology. She has also been a guest speaker on various platforms, including those of APP and Hematocon, and has been a part of many bone marrow workshops. She has contributed chapters for various hematology textbooks and has some publications to her credit. Over to you, ma'am.
Thank you, Dr. Divya, for the kind introduction. Is my screen visible?
Yes, ma'am.
Yes, ma'am.
Yeah. Good evening, everybody. I thank Dr. Zubair for having me as part of this Diagnopool, and thank you so much, Dr. Divya, for the kind introduction. Today, I'll be talking about the diagnostic utility of bone marrow examination in non-hematological disorders. So, bone marrow examination consists of the study of bone marrow of bone marrow biopsy. Some of the common indications for bone marrow aspirate include disorders of the components of the aspirate, including the red cell disorders, the various anemias, white cell disorders, including both acute and chronic leukemias, megakaryocytic disorders, and myeloproliferative disorders and lymphoproliferative disorders. You can also use the bone marrow aspirate to diagnose storage disorders, plasma cell dyscrasias, ranging from MGUS to Waldenstrom's to multiple myeloma. It is useful for studying the iron stores and other infiltrative disorders like metastasis, infections. Bone marrow failure states can be diagnosed with the help of bone marrow aspirates. All in all, they are used for morphological examination, and additionally, immunophenotyping, cytogenetics, and molecular studies can be done on bone marrow aspirates.
Ma'am, the slides are not changing.
Not sharing?
No, it's not changing. You're still in the first slide.
Okay, then I'll reshare.
Yeah. Yes, ma'am.
Is it moving now?
Can you change now?
Yeah, I'm changing.
No, it is not. Can you do a slideshow?
1 second.
Yeah, now it is moving.
Okay. It's moving now, Dr. Divya?
No, ma'am. It is. The slides are not changing. I think you can just present without slideshow, like that is it.
Okay, I did from the slideshow as well. I'm not sure why it's not moving. I'll just try once again. Just one last time. Is it moving now?
No, ma'am.
No. Okay, then I'll keep it in this mode itself then. Is this fine?
Just change now. Yeah, this is fine.
Okay.
Okay.
So whenever the aspirate is insufficient or we get a diluted marrow, either because of procedural or due to a pathology in the bone marrow, we then go on to do a bone marrow biopsy. Bone marrow biopsy is also useful for diagnosis in conditions of hypocellular marrow associated with fibrosis, aplasia. There's a lot of necrosis and in failure states as well. In bone marrow aspirate, when bone marrow is involved by a focal disease, a bone marrow aspirate is not that useful and a bone marrow biopsy becomes more useful there. We also can use the bone marrow biopsy to study metabolic diseases. So, by and large, what we know is we use bone marrow aspirate and biopsy to study hematological disorders. Over the next 35 to 40 minutes, what I'm going to tell you is the use of bone marrow studies for non-hematological conditions. These could be infections, metastasis, and osteopathies. These are the three headings under which I'll be talking. So, to understand bone marrow infections, let's begin with a case study. She's a 35-year-old male patient admitted with low-grade fever for about 2 months. He has one small cervical lymph node. Besides that, nothing else. And an FNA found on that shows a reactive lymphadenitis. He was given antibiotics, but the patient didn't respond. Fever persisted. He had loss of weight. No associated organomegaly. A chest X-ray done was normal. A bone marrow aspirate was advised, which yielded a dry tap. Subsequently, a bone marrow biopsy was done, and what we saw in the bone marrow imprint was acellular material. Before the bone marrow biopsy could be processed and we could see the actual slide, the imprint was studied and it just showed acellular material and an occasional histiocyte. So this was, I wanted to put my pointer, but then since it's not in PPT mode, I can't show you. So this is the occasional histiocyte in the bone marrow imprint smear. And after we got the bone marrow biopsy, what we saw were sheets of histiocytes replacing the large parts of the hemopoietic cells of the marrow. Additional stains were performed on this and a diagnosis of Mycobacterium avium intracellular was made. So what were the additional stains we did? One was a Ziehl-Neelsen stain, and you can see that the macrophages are loaded with AFB. A PAS stain done also was positive. Now you may ask me how come PAS stain is showing positive, but in Mycobacterium avium intracellular, these organisms stain positive for PAS, whereas in the routine AFB, we do not get PAS stain as positive, only ZN stain comes to be positive. When we went back to the lymph node aspirate and saw the lymph node aspirate, there were some negative images of the mycobacteria in the lymph node aspirate, and when these were subsequently stained with AFB, they turned out to be AFB positive. So Mycobacterium avium intracellular is associated with granulomas in the bone marrow biopsy, and we see sheets of histiocytes. We need to perform AFB and PAS stain to rule out this condition. Some of the other conditions where we come across granulomas in the bone marrow include tuberculosis, sarcoidosis, fungal granulomas, histoplasmosis, and cryptococcosis. Leprosy, Crohn's disease, or drugs like phenytoin can also give rise to granulomas, and also autoimmune disorders such as rheumatoid arthritis. We come across granulomas in the bone marrow. Granulomas are not easily aspirated because these are usually associated with fibrosis. So when you do an aspirate, the granulomas do not get aspirated into the aspirate. So very rarely we come across, and this was one such case where we came across a granuloma in an aspirate. In the biopsy, we come across these caseating granulomas sometimes, which are usually paratrabecular in location. There is caseation necrosis. You don't find the typical granulomas that you come across in lymph nodes, where there is central caseation surrounded by epithelioid cells. But in bone marrow, it's in tuberculosis, these are paratrabecular in location. They are associated with some histiocytic clusters. Then the Langhans giant cells is also present along with it. And an AFP stain turns out to be useful in these conditions. This is another case where we find a proper Langhans giant cells, and many times we come across necrosis and collections of histiocytes, more so in cases associated with HIV infection. This is another case of Mycobacterium avium intracellular where ZN stain and PAS stain both show histiocytes loaded with AFB. We see granulomas in sarcoidosis as well. Sarcoidosis granulomas are slightly different from those of tuberculosis granulomas, and these are associated with dense fibrosis. These granulomas do not have central caseation, and you find various granulomas of varying size throughout the bone marrow biopsy. In addition, if you look carefully, you can also come across these Schumann bodies or calcified deposits within the macrophages, as well as asteroid bodies. See, these are some asteroid bodies which you come across, and they are diagnostic of sarcoidosis. Another infection that we can diagnose generally with a peripheral smear itself is the malarial parasite. The various stages of malarial parasite can be seen on a peripheral smear. But we have come across malarial parasite in the bone marrow aspirate many times in cases of PUO, when aspirate is performed for case of PUO. And here we see, we do come across occasional forms of malarial parasite. In this picture, you can see the gametocyte of Plasmodium falciparum. But more commonly, you will see these macrophages loaded with hemozoin pigments. These are small nodules, if you can see, within the macrophage, and each of these nodules corresponds to one gametocyte. So this malarial pigment is you should be aware of the fact that even if you don't find any of these the different stages of the malarial parasite, presence of these pigments should give you a suspicion that it could be a case of malaria. We also can rarely see cells in the bone marrow aspirate. Another common infection seen in Bihar and Northeast is the Kala Azar or Leishmania donovanosis. And these cases present with fever of long-standing duration. There is splenomegaly. And what is the clue to look for these LD bodies are the presence of numerous plasma cells in the aspirate. These are the plasma cells with a perinuclear Hoff. And in addition, you'll find both extracellular as well as intracellular LD bodies. LDs are nothing but oval in structure. They have a round nucleus and a kinetoplast. And the clue to look out for these is the presence of plasma cells and clinical history. So similar to LD bodies, you also come across histoplasma. Histoplasma looks slightly different. These are macrophages loaded with histoplasma. What you see here are concentric nuclei within a capsule. And these are very much, it's easy to get confused with LD bodies, but if you look carefully, these are more concentric in structure, the nuclei, and they do not have kinetoplast. Whereas in LD bodies, there is both the nucleus and the kinetoplast. Likewise, in the bone marrow biopsy, you can find macrophages loaded with histoplasma and loaded with LD bodies. If you see in Kala-Azar, these macrophages are just packed with LD bodies. Numerous of them are present inside the macrophage. Whereas in histoplasma, there are fewer number and there is a definite space around each of the nucleus. To visualize this better, a pass stain can be performed which stains the capsule of the histoplasma. Another condition which gives rise to granuloma in the bone marrow biopsy is Cryptococcus. Cryptococcus we normally see in the cerebrospinal fluid in routine examination with the India ink preparation. We can see Cryptococcus in the bone marrow biopsy as well, and these are capsulated organisms which have a central round nucleus. The silver methenamine stain and the pass stain can be used to highlight this capsule. So HIV infection gives rise to myelopathic changes in the bone marrow, and it can be identified when we look at certain changes within the bone marrow, and then if we have not got the history at the right time, and later when we ask for history, patient turns out to be HIV positive. There are various causes of anemia in HIV infection. It could be drug induced, or it could be due to because of the immunosuppression, parvovirus B19 infection, and thereby causing pure red cell aplasia. There will be associated tuberculosis, and sometimes associated malignancies also can give rise to anemia. Some of the features that we come across in HIV infection are gelatinous marrow transformation, where the stroma has a pinkish hue in the aspirate, and this pinkish hue is referred to as gelatinous marrow transformation. There is associated plasmacytosis in HIV infection as well. And similarly, in the bone marrow biopsy, this is the eosinophilic gelatinous marrow transformation in the marrow, which replaces the hemopoietic cells, thereby causing pancytopenia and anemia also sometimes, associated with focal fibrosis, and occasionally granulomas are also seen. So, bone marrow biopsy is very useful in the study of bone marrow infections. And whenever we have a case of pyrexia of unknown origin, aspirate and biopsy together done will give us a lot of information. We can rule out a lot of infections. Coming to the next category, which is metastasis. Let's begin with a case study. This was a 65-year-old lady. She was admitted with low-grade fever for about 3 weeks. She was an asthmatic on steroids for 5 years. And her biochemical parameters were all within normal limits. Blood and urine culture was also normal. X-ray, chest, everything was normal except that she showed some diffuse osteoporotic changes. But 2 weeks after that, we found that she was having a limp. And being an elderly lady with fever and diffuse osteoporosis, we thought of myeloma, multiple myeloma. A bone marrow aspirate was done. It was diluted. A bone marrow biopsy was subsequently advised, and this is what we saw in the bone marrow biopsy. So, look predominantly normal, hypocellular marrow, normal for the age, except these small clusters within the biopsy. What were these cell clusters? And when a CK was done, they turned out to be positive. So, this indicated that it was a metastatic deposit. And then we went on to look for the primary. So metastasis can be picked up on bone marrow aspirate. Usually when we make a number of aspirate slides, 5-6 slides we screen, and we find that more or less it looks normal, except there is some anemia and all of that. But if we look carefully, we may come across sometimes clusters of these atypical cells, which could give you a clue that there is probably metastasis. And the bone marrow biopsy also shows replacement of hemopoietic cells with clusters either focally or diffuse replacement of the marrow with atypical cells. So bone marrow biopsy in malignancies, whenever bone marrow is involved, it means patient is in an advanced stage of the malignancy. It is usually done as part of staging. And when the patient has suspicious pathological fractures and or fever of a long duration, has anemia and weakness, the biopsy can give you a clue that it could be due to metastatic deposits. When the PET scan is done, it may show hotspots on the bone scan and a spinal cord compression also may be seen. Biochemical investigations like increased alkaline phosphatase and increased calcium levels also are seen in cases of bone marrow involvement of metastasis. Anemia could be due to anemia of chronic disease, iron deficiency, or microangiopathic hemolytic anemia seen in some cases of gastric carcinomas, myelopathic anemias, and there could be pancytopenia, thrombocytopenia, and carcinocythemia. Carcinocythemia is when we come across circulating tumor cells within the marrow. The breast is most common organ which causes metastasis in the marrow in women and prostate in men. Other organs which cause bone marrow metastasis are lung, kidney. In children, it is mostly neuroblastomas. So when we do a PET scan, there is we come across a diffuse uptake, and which indicates that it could be a metastasis. What we see in the peripheral blood is a leukoerythroblastic blood picture. Here what we see are neutrophils, some myeloid precursors and nucleated red cells, and this could give you a clue that it generally shows that bone marrow is irritated because of something, either because of fibrosis or because of a foreign cell within the bone marrow, and that is why there is a leukoerythroblastic blood picture. And these are rarely we come across circulating tumor cells within the peripheral blood. Now, there's always a debate whether an aspirate is enough or a biopsy also needs to be performed. An aspirate is less painful, easy to be done, so it is preferred, but biopsy is a little more painful. So many studies have been done to debate on whether both are required or only one of them is sufficient. So, in an aspirate, the disadvantages are if there is a focal metastatic lesion and the needle hit the correct area, we may not be able to get the correct adequate material. And if there is associated fibrosis because of aspirate becomes non-aspirable and hence leading to a dry tap. If you do a bone marrow biopsy, the advantages are you could get a clear architectural pattern is seen. The morphology of the cells in the biopsy can give you a clue to the source of primary. And in addition, you can do immunohistochemistry on the biopsy to help you type the malignancy. So, like I told you, many studies have been done, and it has all the studies have shown that a combination of aspirate as well as biopsy is superior in detection of metastasis. So, the most common site where we do this bone marrow aspirate and biopsy is the iliac crest. And why so? Because this remains hemopoietically active till very late stage in life. And usually the axial skeleton, this is part of the axial skeleton, and this usually is affected more commonly. And earlier, what they used to do is do biopsy on both sides of the iliac crest. Now, even one side is enough. Unless there is a strong suspicion and one side is negative, then we don't do on both sides. So, when we look at histopathology of bone marrow metastasis, we look at the tumor load. There could be isolated tumor cells micrometastasis, large masses, or total marrow replacement. And we can also see the tumor morphology, and the secondary effects that we see because of metastasis can be identified in a bone marrow biopsy. So isolated tumor cells are individual cells which, when we carefully see, can be seen in amongst the hemopoietic cells. Micrometastasis is defined as small clusters of cells measuring less than 0.3 square centimeters, and usually it predicts distant metastasis and early relapse. So, and they can be confirmed with the help of immunohistochemical stains. Focal deposits, like in this case, where there are small clusters replacing the hemopoietic cells, and diffuse replacement, where entire hemopoietic marrow is replaced by these sheets of signet ring cells in a case of mucin secreting adenocarcinoma, and they turn out to be mucicarmin positive. So, whenever there is a metastasis, we find certain additional changes in the surrounding tissue of the bone marrow, and this is known as tumor myelopathy. So, there could be lymphoid aggregates, there could be a neutrophilic response, eosinophilic response, or stromal edema. And usually we come across angiogenesis also, like we see in other solid tumors, and development of blood vessels at the growing edge of the tumor. And a flow chart is there where we can, once we see an unknown primary in the bone marrow, unknown carcinomatous deposit in the biopsy, we can go in for immunohistochemistry. First, we will do a CD45 and a CK to ascertain that it is not a hematological malignancy. And after doing CK, we do CK7, CK20, and the whole range of antibodies can then be performed to detect the unknown primary. So this is a case, an example of a neuroblastoma which we saw, clusters of small metastatic round cells, and you're seeing this pseudo rosette formation, and the biopsy showed similar small round cells. They turned out to be S100 and NSE positive. Likewise, you can do other many markers and identify the primary in a lung carcinoma, a TTF1 or a CK to see. We have seen cases where there is only fibrosis in the marrow and the tumor cells are so much compressed. We do not know, we can't make out the morphology of the marrow cells, and when a CK is done, all these compressed cells turn out to be CK positive, ruling out a myeloproliferative neoplasm. So this was a case of a melanoma, and the biopsy showed pigments here, and turned out to be HMB45 positive. And you can do additional specialty stains, like on an aspirate you can do mucicarmin, PAS and Fontana to identify the primary. So whenever you see fibrosis and necrosis in a marrow and you're not able to make out any other thing, it means that there is something sinister happening within the marrow. You're probably not seeing the correct area, or you may have to advise a repeat biopsy on another area, on another site. So usually when accompanied by fibrosis and necrosis and it is not matching with the clinical history, you will have to look for deeper sections or repeat biopsy on the site. There are some bone changes also that we come across in metastasis. It could be osteolysis, can be local or generalized. Local is to the site where the metastasis has happened, or generalized when there is parathormone-like peptides released because of as a part of paraneoplastic syndromes, and there is diffuse osteolysis. There could be osteoblastic lesions, and when you see these osteoblastic lesions, usually seen more in cases of breast and prostate malignancies. Osteosclerosis is also seen where there is new bone formation over here. In all these cases, you see all this is new bone formation. There is deposition of new bone on the existing endosteal surface, or there could be small bony spicules within the marrow spaces. That is new osteogenesis. And there could be tumor-induced osteomalacia as well. So metastasis is a very important feature you can pick up by studying bone marrow biopsies. Finally, we come to osteopathies. So when it comes to bone metabolic disorders, bone biopsy is usually not done because it's a painful procedure. Orthopedicians use a very large needle to do bone biopsies. But if you study the bone marrow trephine biopsy, it gives you a lot of information about some underlying metabolic disorders, because you can see the cortical and trabecular bone, and this helps you the morphology of the cortical and trabecular bone gives you a lot of information about any underlying disorder. So normally when we see a bone marrow biopsy, we see that the bony trabeculae are uniform in thickness. The surface is very smooth, the endosteal surface is very smooth, and usually lined by a few osteoblasts, and you may find some amount or some few osteoclasts as well. So we know now osteoblasts and osteoclasts are very important in the bone remodeling and the general bone structure. So, how do you identify these osteoblasts? They look very similar to plasma cells. These are plasma cells. These are osteoblasts. It looks as if the nucleus is being pushed out of the cell. And in plasma cell, it's kind of similar, but there is a perinuclear half, which is not present in osteoblasts. And these osteoblasts are seen lining the endosteal surface. This is the ideal location. And normally many are not present, but a few areas show osteoblastic lining. Now osteoclasts. Osteoclasts are multinucleated giant cells, and like I told you, they are very important for bone remodeling and bone resorption together. So they are very important for the bone structure per se. Now you find some of them you find across near the bony trabeculae, but when they are increased in number, they usually mean it is something else. So the major osteopathies which are detected on bone marrow biopsies are osteoporosis, osteomalacia, osteosclerosis, osteopetrosis, primary hyperparathyroidism, renal osteodystrophy, and calcium deposits. Now, this is a structure of a normal bone marrow, and the stain performed here is the von Cossa stain. These are not usually performed these days because earlier to detect these we use it was being done. What were uncalcified sections were being studied, and these bony bone marrows were embedded in resin material like methyl methacrylate, and sections were additionally subsequently stained. So this is the black calcium deposit, which indicates that the bone is mineralized. And what you see here is the pink line is the unmineralized bone front. Okay, that is the periosteum. And in contrast, if you see in a case of osteomalacia, there is very irregular deposit of calcium, and the cortex is very uneven. See over here, this is all the unmineralized bone. The pink part is the unmineralized bone. Other stains that you can use to detect these are the pearl stain, which gives a blue line to this. Now, osteoporosis. Osteoporosis, earlier it was used, for detection of osteoporosis, it is generally recommended to study the transcortical iliac X-rays, but that happens in a later stage of the disease. Osteoporosis can be detected in bone marrow biopsies when they come in for other conditions. Generally, in elderly patients, they are diagnosed for some other, they're investigated for some other condition, and when we study, we find that these bony trabeculae are very slender in nature. They have, loss of interconnections between the bony trabeculae. There is a buttonhole phenomenon, and they're very, very fragile. So when you're doing the biopsy itself, as if the needle is going inside butter. And these patients are more prone for pathological fractures. what you find is there is too much of marrow and very little bone. So this you should remember to diagnose a case of osteoporosis. These are other pictures where there is too much of marrow and too little bone. You just see the small, slender, bony trabeculae, and they are indicative of osteoporosis. So this is the transcortical iliac crest X-rays that we normally use to detect osteoporosis, but it can be detected much earlier when you see a bone marrow biopsy. Now, osteomalacia and rickets is a condition when there is failure of normal or timely mineralization due to deficiency of vitamin D. So there is deficient either because of deficient intake or some underlying metabolic disorder. You get this very soft bone where the cortex is markedly thickened, and you find that the mineralization front is regressed. As you see in this case, very thickened bony trabeculae and very little marrow. And this marrow also is fibrosed. So what you're seeing here is too much bone and very little marrow. And this von Cosa stain I showed you a little earlier, there is a very distorted pattern of this calcium deposit. In the very little mineralized bone is present. And an aspirate done is usually dry, and patients usually have a leukoerythroblastic blood picture because of the extensive fibrosis. Osteosclerosis is increased mineralized bone mass, and it is seen in conditions like all these myeloproliferative disorders, metastasis, systemic mastocytosis, Paget's disease, multiple myeloma, and in osteopetrosis also. It can be diagnosed with X-ray. Histologically, it shows the deposition of bone on the pre-existing endosteal surface or a deposition of new bone within the marrow. So here what you're seeing is too much of bone, very thickened, irregularly thickened bony trabeculae. Marrow is present, highly fibrosed. This is in a case of primary myelofibrosis, and this is known as osteomyelosclerosis. This is in the later stage of primary myelofibrosis that you come across, and we can come across this kind of picture in metastasis as well. Another condition which is useful to detect on bone marrow, we have picked up many cases of hyperparathyroidism on just seeing bone marrow biopsies. Now, hyperparathyroidism is due to increased parathyroid hormone. There is increased calcium, and due to which there is irregular mineralization of the bone, and increased osteoclastic as well as osteoblastic activity is seen in hyperparathyroidism. So here you're seeing these clusters of multinucleated giant cells. These are not megakaryocytes, these are osteoclasts. And you're seeing the bony trabeculae is irregular on surface. Very there are irregular. The entire surface is irregular. This is because the osteoblasts have eaten up the surface of the bony trabeculae, and a case of parathyroid adenoma, and subsequently after eating up, cysts form in the bony trabeculae, and these cysts are visible in the X-rays. So whenever you come across such kind of cases in a bone marrow biopsy, always insist on looking at the X-ray and take some clinical history on the patient. Renal osteodystrophy as well. There are a number of bony abnormalities present, similar to what we saw in hyperparathyroidism. And here we see that the bony surface is irregular in surface, it is not smooth. There is associated paratrabecular fibrosis. Look for the specific band. And then when you ask the patient for history, whether he has any features of raised creatinine, urea, you will come to know that there is probably some renal changes happening within the marrow. And as this progresses on to like this, so when there is osteoblastic proliferation along the endosteal surface, then this the bony trabeculae increase in thickness, following which osteoclasts take over. They start eating up at the bone, and the surface becomes irregular. There are clusters of these osteoclasts present at different stages, subsequently then followed by bone marrow fibrosis. So these are the stages that we come across in hyperparathyroidism. And very much so we see in cases of renal osteodystrophy as well. So these are some more pictures. This is known as lacunar absorption, where the bony surface, the osteoclasts eat up into the bony trabeculae and form a kind of lacuna. And when this lacuna increases, it dissects through the bony trabeculae, leading to osteitis dissecans. This is another case of renal osteodystrophy where there is lacunar resorption, and then this is tunnel resorption. This is known as tunnel resorption when there is a hole created within the bony trabeculae. Let's look at this case of a 1-year-old child. He had pallor and stunted growth and an enlarged liver and spleen. He had anemia and thrombocytopenia. Total count was normal. And when we looked at the bone marrow, the peripheral smear, we saw some myeloblasts, normoblasts. There was and some teardrop cells as well. Here the teardrop cells. So a leukoerythroblastic blood picture. We thought it could be a hemolytic anemia. Retic count was advised, it was 1.5%. And when we did the HPLC, there was no hemoglobinopathy. A skeletal survey was advised. And what we found, this was a small child, so a full body skeletal X-ray. There are transverse bands in these diaphysis of the femoris, and there is a flask-shaped deformity, or Erlenmeyer deformity, this is called as. Similarly, there is increased density in the ribs and spine as well. So this is a case of osteopetrosis. In osteopetrosis, osteoclasts fail to perform their function of resorption, bone resorption, thereby leading to thickened sclerotic bone. And patients present with pallor, abdominal distension, pathological fracture, dental caries, nasal obstruction, and hepatosplenomegaly. So this is a biopsy of a case of osteopetrosis where you find these irregular cartilaginous deposits. So in children, these cartilage also gets remodeled, and because of failure of our osteoclasts, cartilage irregular deposits of osteoclasts are also seen in the biopsy. This can be both congenital and familial, so and are usually associated with the mutation in the ATP6 gene. The last condition is the presence of crystalline deposits. When we study the bone marrow biopsy carefully, we do come across crystalline deposits. This is an example of a 34-year-old male patient who was undergoing chronic dialysis prior to renal transplant, and he presented with pancytopenia. What we found in the bone marrow biopsy are these large crystals with spicules, needle-like crystals in a radial manner, and they turned out to be oxalate crystals. These patients are more prone for renal stones and hepatosplenomegaly. So, in addition to this, we come across some mild paratrabecular fibrosis. These crystals, there is a foreign body giant cell reaction as well. So, to conclude, the take-home message for all aspirates and biopsy, make sure you look it under the scanner view. You can see the morphology of the bony trabeculae and the cellularity of the marrow, and this gives you a lot of clue to the actual diagnosis. All cases of PO should be subjected to the bone marrow biopsy to rule out causes of granulomas, fungal disease, and also metastasis. Stains like reticulin stain, the trichrome stain, Zn stain, and PAS stain is very helpful for diagnosis is not very clear, and in cases of granulomas. Numerous infections with systemic manifestations can be recognized by examining the peripheral smear and bone marrow. Examining the bone marrow aspirate along with the biopsy also not only helps in staging of the malignancies, because when you see there's a bone marrow metastasis, it automatically becomes stage 4. But it is also useful detecting the unknown primary, because you can do a number of IHCs and studying the morphology and architecture of the metastatic deposits. Whenever there is bone marrow necrosis or fibrosis, look for something more within the marrow. Definitely it is not benign. Then bone marrow refined biopsy is a useful tool for detection of expected and unexpected osteopathies. Histology with a high index of suspicion along with clinical and radiological and biochemical data will give you an accurate diagnosis. With that, I end my talk. Thank you very much. And my sincere thanks to Professor Dr. Tejinder Singh, who is my mentor and guide, and for sharing me some of his pictures. Thank you so much. If there are any questions, I'll be happy to take.
Thank you, ma'am, for this wonderful talk. And first of all, thank you for accepting the offer to come in this small form. As I said, we were previously focusing on training on lab technicians. We took a different step this time by having a topic catering to pathologists, and I'm happy to see the response. We will continue to have a mix of both the topics in the future as well. As Dr. Tejinder Singh sir is here, if sir could just add a few words on this topic, it would be an honor for us. Or any other participants. I don't know if sir can answer. Yeah. Any other comments from other audience? What I have understood is that examining the bone marrow, we have to also look at the other biochemical parameters, especially because many of the conditions you are telling are medical conditions with a lot of derangements in the other biochemistry parameters. So, very important to correlate with the other findings as well. Very good presentation. Thank you. Any other comments, Divya?
Ma'am, any specific precaution that usually as many technicians are involved here, when after aspiration or biopsy while processing, especially in storage disorders or something, anything specific precaution that we have to take?
Specific precaution: ensure that the bone marrow is fixed properly, at least for 24 hours. We receive a lot of biopsies that are not fixed properly. They are coming in, sometimes they are coming in acetic acid, but I prefer 10% formalin. 10% formalin fixed for 24 hours and then decalcified will give a better section than when it is not fixed properly. Underfixed marrows are not very useful. And whenever an aspirate is taken, always make imprint smears at the site of collection, and also make direct smears as well. Because whenever you add an aspirate either into an EDTA or heparin vial, some morphological changes will be there, and there could be a lapse of time by the time the sample reaches the lab to the pathologist, he or she can make the smear. So if direct smears are made at the site of aspirate, it is very useful because there are no artifacts involved in that. Whenever there is EDTA, some artifacts usually creep in and which can alter the morphology of the disease. And always clinical history is very important. We receive cases without clinical history and then we are chasing for that, and the valuable time is lost by the time we give a diagnosis. So clinical history along with the material is very useful.
Any other questions from the audience? I request all to fill the feedback form. Thank you, ma'am, for such a wonderful presentation. I personally got to learn a lot of things. I truly appreciate you and your time taken for this presentation on this small platform. I also thank each and one of you for attending this session during your busy schedule.
Thank you, Dr. Subir. Thank you, Dr. Divya. Thank you all.
Thank you.
Thank you.